Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Orygen, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Welcome everyone. In this webinar, Liz and I will be talking about speech, language and communication needs and the impact on young people presenting to mental health services. My name is Frances Saunders and I work at the Royal Children's Hospital Mental Health Service.
And I'm Liz Morecambe. I'm the Senior Speech Pathologist at the Austin Hospital Child and Youth Mental Health Service.
So in the literature, Liz, there's multiple terms, isn't there, used to describe this difficulty. People use language disorder, specific language impairment, social communication disorder, pragmatic language impairment.
Communication impairment.
Yes. So in this webinar, we're using the term speech, language and communication needs to encapsulate all of these problems.
Having said that though, Frances, I think I'll tend to be using the term communication impairment. That's sort of my go-to phrase that I use clinically.
Sure. And in clinical work, we use lots of these terms interchangeably.
Yeah.
So what we hope to cover are three key things today. Firstly, what does the research tell us about the prevalence of speech, language and communication needs in youth mental health? Secondly, what are these speech, language and communication needs? What do they look like? And how does the mental health clinician recognise these needs in their clients? And lastly, how do these speech, language and communication needs impact on individuals and why does it matter in mental health interventions? So when we look at the prevalence of speech, language and communication needs in the general population and in specific populations, these prevalence figures will vary depending on the research. So depending on what aspect of language, speech or communication is being studied and depending on the severity level reported, we'll see different prevalence rates reported. In the general population though, we know that between 10 and 15% of children and adolescents present with specific language disorder or language disorder. When we look at child and youth mental health services, we know the prevalence is much, much higher. So in this population, we're looking at more than 50% of young people have a speech, language or communication need, very often a language disorder. Many of our clients will have contact with other service systems, so juvenile justice, child protection, out-of-home care. We know that also in these populations, they also have high prevalence rates of speech, language and communication needs and language disorders.
And sometimes, particularly in the younger populations that are related to out-of-home care, we know there are studies that show that that can range up to 80%.
Yes, and I think the Berry Street study looking at out-of-home care in Victoria found that about 60% of their children and adolescents in out-of-home care had a language disorder, but if they look more broadly at speech, language and communication, they saw rates of around 88%, which is very high.
That's right.
But of course, perhaps at a lower severity rate.
Yeah, but it also makes sense, doesn't it, when you think about the development of language. So if you think about language having partly an inherent core and then partly being attributed to exposure and stimulation, where an environment is where there is neglect or lack of stimulation in environments, then we know that language won't develop as well as those children who are spoken to and stimulated frequently.
Absolutely. And we know from research too that coming from a background of social disadvantage or economic disadvantage increases your risk of a language disorder. So children commencing school at age 5, coming from a background of social and economic disadvantage, often their language levels are 2 years behind their peers.
Yeah.
So it has a huge impact.
That's right from the start.
One of the problems in mental health though, Liz, isn't it, that speech, language and communication needs are often missed. And particularly in adolescence and youth, if we think about why this is, it's largely to do, or partly to do with the transition of language in the adolescent years. So children go from primary school to high school, and the language demands increase. So the language the teachers are using are more complex, less concrete, more abstract language. Teachers use less visual supports for teaching, and more of the teaching is primarily through talking. If we think about how adolescents maintain social relationships, this is mediated primarily through language, isn't it?
That's right.
So the language of relationships becomes more complex and much more nuanced. So it's not surprising that these young people are experiencing more difficulties in their adolescent years. So in mental health, the research tells us and shows us that it's in youth, speech and language and communication needs can be masked by their antisocial behaviour, self-harming behaviour, and substance abuse. And of course, given the high risk of these sorts of behaviours, the mental health clinician has to be focused on risk and safety planning.
That's right, yeah.
And often forgets to look at the underlying contributing factors to these sorts of behaviours. So in youth, the behaviour can be the presentation or the measure of the level of distress the young person's experiencing. And if their language levels are low, they're using more behaviour to express that distress rather than their talking or their language skills.
So the clinician might see someone who seems, fairly disaffected in the room, or is negative or seems disinterested rather than engaged, and might just see that as an attitudinal problem rather than maybe this person's not actually able to really engage verbally.
That's right, but they haven't got the skills to do that.
That's right.
And that behaviour can be misinterpreted.
Yeah.
Similarly, some of that unwillingness to talk can be seen as a symptom of their mental health problems. So we know in depression and anxiety, clinicians will primarily interpret this as a presentation of the mental health difficulty.
And caregivers too, they tend to forget sometimes, don't they? So we know that sometimes, even if someone's had a language assessment in early childhood, parents are not necessarily aware of the fact that it may not resolve, but it will change in its nature. And they also may forget about the impact on a young person.
Absolutely. So that impact of the language disorder over time changes, and often parents can think that the child may grow out of it.
Yeah.
And similarly, the clinicians sometimes are aware that the young person has had a language disorder diagnosed, but may not be thinking about how that's impacting on their current presentation.
It's interesting how we tend to think of developmental language disorder as something of young children, and in fact what we're realizing now is that actually adults can present with a developmental language disorder.
Because if it doesn't resolve in late primary school, for most people it's a lifelong difficulty.
That's right.
And challenge.
Yeah.
A typical example of this kind of presentation where the language disorder was masked is that of Jodie. So Jodie was 15 when she presented to ED with increasing suicidal ideation, self-harm, and was reporting hearing voices. She had a brief inpatient admission, and previous to this presentation, she had been well supported by a private psychologist, a private psychiatrist, for generalised anxiety. So clearly by the time she was 15, her symptoms were escalating and were no longer being able to be managed in the community. So after this inpatient admission, she was discharged to a community child and youth mental health team, and she was managed for anxiety, school refusal and selective mutism. She engaged mainly with her treating clinician through writing short notes, and made little progress over several months. So it took a while for her, due to a lack of progress, to be referred for a speech pathology assessment. But when this was completed, it indicated severe receptive and expressive language disorder. And that's not uncommon for those of us who work in mental health, to see these adolescents who
somehow have got through
without it being diagnosed.
That's right.
And in fact, these parents were shocked and actually said, how could you get to year 9 without anyone knowing or teachers realising that she had this language disorder.
Yeah.
So clearly for Jodie, this shows how the relationship between speech language problems and communication problems impact on their mental health. That trying to cope at high school without those skills made life incredibly difficult for Jodie to access the curriculum, but also maintain those peer relationships.
And how anxious she must have felt all of that time, thinking that for all this time there's this confusion about everything, and how much that would have contributed to just a general level of anxiety in just managing all your interactions.
And not understanding why life was so difficult.
No, exactly. Yeah. So we thought we might describe some of the areas of language that, in the way that a speech pathologist might think about them. And on the left side of the slide, we have the communication disorders listed under the DSM-5, which is language disorder, speech sound disorder, childhood onset of fluency, and social communication disorder or pragmatic language disorder. And you'll see that we've colour-coded them so that they, and the colour coding links with the circles on the right side of the slide, which is more the way a speech pathologist might think about the communication, these areas of communication. So that we would match language disorder to language, speech sound disorder and fluency disorder to speech, and social communication disorder to communication. But we have more detailed understandings of these areas, and we also consider them to be interlocking.
That's right, they can overlap or they can exist in isolation.
Yes, so a clinician who meeting a young person coming into their room might find that their client actually can just have one area of difficulty in one of these areas of difficulty, or potentially could have difficulty in all three areas. So the first area we thought we'd talk about would be the area of speech, which we've included articulation, fluency, and voice difficulties. So articulation refers to the pronunciation of words, and someone who's having difficulty with articulation difficulties might make some speech sound errors, such as a lisp, or they might make numerous errors and be quite hard to understand, so that it affects their intelligibility, and they might mumble. So there are some particular disorders of articulation, which include phonological disorders, childhood apraxia of speech, and dysarthrias. So childhood phonological disorder is, something that's more developmental in nature. We would expect children's articulation to be developed by the age of 6, and occasionally you might come across someone who has a residual lisp or a WR, which is left over from that early pattern of speech. We learn speech sounds in an order of difficulty, and that sort of difficulty, particularly in adolescents, can lead to teasing and some impact on self-esteem. But the more severe articulation difficulties, such as apraxia and dysarthria, really impact on intelligibility. And often it's very hard for those young people to actually control the production of sound. So dysarthria is often a neurological disorder where the musculature is hard to control, so they can sound very imprecise and slurred in their speech. And dyspraxia is a motor planning difficulty, so the young person has difficulty controlling the output of speech in terms of like planning a particular sound. So again, their intelligibility can be really severely impacted. And of course, that is going to create ongoing difficulties in navigating relationships. It's hard to be understood. Sometimes even family members can't understand these young people. So it can lead to a lot of frustration, dysregulation. And of course, you can imagine in a classroom, be terrifying to be put on the spot, to be asked a question. It's hard to make friends or maintain friendships when it's difficult for you to just be understood by other people. So we would expect to see high levels of anxiety and depression in young people and dysregulation in young people with these more severe articulation difficulties. Fluency we're all familiar with.
Stuttering.
Stuttering, that's
Hmm.
right. So stuttering, would you like to give us a demonstration of stuttering,
So you
Francis?
can have things like prolongations of sounds where I go to say a word and it's stretched out. So I like snakes or repetitions. Mum, I want a drink.
Yeah, blocking's always really
Blocking.
difficult to watch. I want to go out to lunch.
Absolutely.
So you can see how stuttering is going to impact again on just the capacity to relate to people. Listeners often find it very hard to manage someone who has a severe stutter, don't know how to help that person get through a conversation. And the young person with the fluency problem is very aware of this, so it creates a lot of social anxiety for young people who have ongoing and particularly more severe fluency disorders. And the last area, I suppose, is voice. So voice is the production of voice using vocal folds. We think of voice as, in terms of its quality, loudness, and so the difficulties of voice would include something like hoarse voice. Been cheering at the footy all weekend, have a hoarse voice. Go Richmond. You can have transgender people may have problems with adjusting the pitch of their voice to match their new gender profile. So that would be something that would be worked on with voice. People might have a loss of voice due to conversion disorder. So there's a psychological reason behind a voice disorder. And the fourth category of voice disorders are really structural issues where maybe someone has a cleft palate and has a very hypernasal voice, so their voice comes through their nose and they can't control that.
So language.
Yes, language. So language refers to how we understand others and how we express ourselves and speak to other people. And language disorders are, the capacity for language competency is highly related to our ability to read and write. So reading and writing is really extension of our oral language competency, really. So that's why we often refer to academic difficulties in terms of maybe someone being a flag for someone having an oral language difficulty, because we know they're so interrelated. So we think of I think of language disorders having two main components, apart from being expressive and receptive or speaking and understanding. We think of structural aspects of language or grammar, or we might call it syntax. And we think of grammar as being the glue that enables us to link different ideas together in order to present a whole range of ideas when we need to negotiate something or explain something. Grammar is the glue that allows us to do that. So, for example, if someone has very simple grammar, so an adolescent or a young person who's got a language delay will have simple grammar, and they might present one idea or two simple ideas in a sentence. And often their language then can come across as quite abrupt.
Or they can sound rude.
Yeah.
They haven't got the ability to explain themselves.
That's right, quite direct. So, for example, someone might say something like, I want my skateboard, I'll do my homework. So we've got two simple sentences, one with each idea. But if we have better grammar, we can link some of that together and express ourselves differently with the same intention. So we could say, if I do my homework, would you give me my skateboard? And immediately, by that more complex use of grammatical language, it sounds more diplomatic, sounds softer, it sounds more like a request than a demand. So the use of grammar is pivotal to being able to be assertive and, I suppose, navigate more difficult social situations. And the second part of language is what we call content or semantic meaning, which is referring to the meanings of words and language. And in young children, this refers to word knowledge and vocabulary. But when we hit about grade 3, 7 or 8, we start to develop an understanding and use of the more complex areas of language, higher levels of language, whereby language becomes more ambiguous, where words have two meanings, where we use lots of expressions such as pull up your socks, where we actually don't mean pull up your socks, we mean, do better. And this continues on into adolescence and adulthood, where we use a lot of innuendo, sarcasm, inferred language. In school, teachers will be using more abstract language, like you've already referred to. So this figurative or non-concrete language keeps developing. And the last area of communication is social communication. So this is the how-to of how we use language to interact with other people. So I think of this again in two different ways. So the first way is the non-verbal use of communication. So how we pay attention to the situation we're in, the person we're talking to, how we're going to adjust our language because we're actually talking to a much older person or a much younger person. And being able to take their perspective on board before we even start talking, we might think, how much does this person know? How much information do I need to give them before I tell them about the event I want them to know about? So before we even start, we have to consider the person in front of us and the context that we're in. And then we start to pay attention to their expression, their eye contact, their proximity to us. We standing too close, so they're looking uncomfortable about that. Do we need to take a step back? Is this person looking happy or sad? Confused? Do I need to repair something? Is my conversation confusing for them? Are they looking so upset that I actually need to think about how empathically I respond to them and change how or what I was going to say? So that's the non-verbal aspect of social communication. And then there's the verbal aspect, which is, again, how am I going to start this conversation? And what are we going to talk about? And oh, this is getting a bit boring for me now. How am I going to change the topic or end this conversation? I actually need to leave, but how am I going to exit the conversation politely? And then for young people in the classroom, how do I interrupt? How can I say no to my friend without upsetting them? So it's really the how-tos of all the difficulties we have around social interactions and how do we say things differently.
So moving on, we've talked about in detail about how understanding and using language is foundational to our mental health and our well-being. So we want to think about what's the impact on the individual client. So we know that, as we've already talked about, that our ability to use language and communication impacts on our development of peer, family relationships. It also impacts on our development of social skills and our internalisation of social codes. It impacts on our ability to self-regulate our behaviour, to use self-talk, to problem solve, to negotiate with other people. Another area that's important, particularly in mental health work, is expressing our emotions. And for young people with speech language and communication needs, they often have a very limited vocabulary when it comes to expressing emotions and might know emotions like happy, sad and angry, but have more difficulty with more nuanced emotions like annoyed or frustrated.
Or regret.
Yeah, and in this way they might have difficulty actually explaining to the mental health clinician how they're feeling and experiencing the world. We also know that when young people struggle with speech, language and communication, that it impacts on their self-esteem and their positive self-image. The other key aspect for young people is that we know these difficulties also impact on their access to learning and their ability to find work. So speech language is key, speech language communication is key to learning to read and write. This has talked a lot about oral language skills, and learning to read and write in turn impacts on our academic success, And often this is related to our ability to remain at school and then access employment. We know young people with language disorders have much more difficulty accessing employment as they leave school. So speech, language and communication problems for young people can be a lifelong and kind of a hidden disability,
Yes,
as
yeah.
we've talked about, that often people don't know because we can get by with saying very little. We can mask by just not talking very much so that
Yes.
people don't know that we're
That's
having
right.
trouble. So thinking about what the impact is of these difficulties in mental health settings, the biggest issue for all of us as mental health clinicians is that our interventions are verbal. So if we think about the most common ones like CBT, family therapy, ACT, individual therapy, psychotherapy, they all require talking and listening. And often we require our clients to read or write or keep a thought journal or a behaviour journal. So our young people with speech, language and communication needs are really disadvantaged in our environment. So thinking about that, it's more than half of the young people we see have these needs, that our therapies do need to be modified and we do need to adjust our therapies so they're accessible to these young people. We also need to keep in mind that for any of us, when we're under stress, our ability to use and understand language decreases. So we all know when we lose our keys and we've got to get out the front door, the kind of language we use is much less sophisticated than when we're operating in a relaxed environment. So thinking about our young people with mental health problems and speech, language and communication needs, they're really in a situation of disadvantage where their language skills are under a lot of pressure.
Yes, yeah.
So we want to think about when a young person comes to one of our mental health services, what is the experience like? How will they engage with our service? What will be the challenges for them? So we know when they come to reception, they have to fill out forms, they have to say who they want to see. They often have to read documentation about privacy, about confidentiality, and all these terms are quite abstract. And for some of our young people, they'll be terms that they're not familiar with. They then meet the clinician. The clinician will then explain about the service, and the clinician might use terms that, again, the young person's not familiar with.
We have a lot of jargon in mental health, don't we?
We do. We have our own language that we
That's
use. Even when we try and make it simple, I think we often revert to what we know and what's easiest for us to say, don't we?
I think one of the most, the one that has always struck me is when we say to people, are you able to keep yourself safe? Which is so commonly used in mental health, but I don't think ever used outside mental health. Outside mental health, the term safe refers to an attack from without, not from an emotional struggle within.
And looking after yourself in that situation. The young person has to talk about their own experience, so they have to be able to provide a coherent narrative, a story about their experience or their life and what their difficulties are, and they have to provide this in a sequenced and a logical way, which our young people with language disorders in particular struggle with. They also need to be able to ask the clinician questions and answer questions. They need to be able to clarify if they don't understand what's going on, or sometimes they might need to disagree. And again, young people with language disorders may struggle with all of these skills.
Might just leave the room.
Yes, and that happens too. As we talked about before, they might have a very limited emotional vocabulary, so they might have difficulty actually conveying the intensity of their experience with the right words that the clinician will be able to understand. They might be challenged by the abstract language and concepts used in therapy, thinking about thoughts, emotions, behaviours and what that means. They might have difficulty with self-reflection and self-talk and understanding their own thoughts. They often feel overwhelmed by conversations and listening to others.
You'll get people objecting to all the questions. Do you get that? People say, you're asking too many questions.
They might also have difficulty with reading the body language and the facial expressions of the clinician. And very often we find they fatigue with too much talking and too much listening. So our clinical sessions of 50 minutes are often way too long for our young people who struggle with understanding and using language and reading verbal and non-verbal communication. We know too, as we've mentioned before, they'll have reading and writing difficulties, so all the form filling and intake procedures that we have might be extremely challenging for them. And those really important documents like recovery and safety plans might be very difficult for them to engage with, both verbally, but then taking that written paperwork home, they might struggle to decode it or understand it.
Yeah. So what are the red flags that you might think about that might give you a clue that your young client has a speech and language communication need or a communication impairment? So initially you could think about the history. So if there is a history of language learning difficulties in the family, or the young person has a developmental history that indicates that they've been slow to learn to talk or slow to put two words together, that would be a red flag. We've already talked about early neglect and socioeconomic disadvantage and trauma having significant impacts on the development of language. So that would definitely be red flags to think about. And I suppose we've also alluded to the fact that there's a strong correlation between oral language competency and academic performance. So if your client has academic difficulties at school or is refusing school, has had poor school attendance, or has dropped out of school, there would be other reasons to think about potentially this person has a speech and language communication difficulty. And then, of course, the other major area is social difficulties. So if someone is isolating themselves or having difficulty maintaining relationships, this is another key area to think about when you're considering whether or not they might need a speech and language assessment. But there are also things to notice in the room. So if you're thinking about how long it takes for someone to answer your question, I think for therapists in the room to think about their own behaviour. How much am I having to repeat myself for this client? How many probes am I needing to ask to get the information? Am I feeling confused by this client's answers? I'm not sure what they're talking about. I need to clarify, get them to clarify who or what they're talking about.
Or the answers might be off the point or tangential.
That's right. Are they speaking in sort of simple short sentences like we've demonstrated before? Do they need me to repeat things? Do I need to change the way I'm asking my questions? Am I noticing any little grammar mistakes? Or is their conversation very simple and non-elaborative? So they're not really adding extra information. There's sort of a sense of poverty of language or poverty of thought in terms of an ongoing reciprocal conversation. And if I ask them about an event, is it difficult for them to tell me in a logical, cohesive, sequential way? So they would be things that you would think about as red flags for someone needing a speech and language assessment.
And I often think if the clinician in the room is having to work very hard to engage the young person in language and provide lots of supports and scaffolding, that's also a sign, isn't it?
That's right. And I think that's where you were saying earlier, sometimes we can just go to, oh, they're anxious or they're depressed, it's the mental health issue that's in the way. But I think you also need to think about maybe there's something else as well, and maybe this is a communication impairment. Yeah. So there are particular, for some of the mental health, more common mental health disorders, there are particular communication and language difficulties that we know about. So we know that people presenting with anxiety and depression are highly likely to have a speech and language communication impairment. And this will show up by having difficulties with explaining themselves, having comprehension problems in the room or demonstrated at school, having poor social skills and poor social interactions, difficulties with friendships, and having poor negotiation skills, which families might just talk about. So lots of arguing at home, negotiating issues at home. So anxiety and depression have high rates of, I think it's something like 3 times the number of people with communication impairments presenting with anxiety and depression than their same age peers. We know that with ADHD and behavioural disorders, there are high rates of comprehension problems and confusion. And we see with ADHD, often there can be a lot of pragmatic difficulties. So we can see excessive talking, fast rate of speech sometimes, difficulties with interrupting, difficulties with proximity, which gets in the way of social relationships, and poor coherence in the way that they are able to explain themselves. So again, difficulties with that logical, sequential, coherent narrative. We know that developmental language difficulties, communication impairment, speech language communication needs is actually a marker for the vulnerability for the development of psychosis. And in particular, what we see are semantic and pragmatic difficulties with this particular group. And we see a lot of difficulties with meaning, both the use and understanding of meaning, tangential responses in conversation, and poor coherence in explanation and conversation and narrative. And similarly, DSM-5 has somewhat blended together the range of autism spectrum disorders. So for the group at the more severe end, we know there are really significant communication impairments.
Both language and social communication.
Yes, and they can be range from quite bizarre understandings of words and use of language, and very, very poor social communication. So a real absence of eye contact and obliviousness to, the person opposite in extremely in profound ASD, moving right through to people with what was once known as Asperger's, so people who have normal intelligence but have persisting problems in their social communication with more literal understanding of language, so difficulties with that abstract thinking, that figurative language we talked about, not being able to understand all the nuanced language and social communication skills, poor conversational turn-taking, and difficulty with taking perspective of others.
So in review, what we'd like you to remember is that more than 50% of young people attending our mental health services will have a speech, language and communication need. So it really is something that each of us needs to look out for and really start thinking about in any client interaction that we're having.
That's right. And we know it impacts on self-esteem, relationships and friendships with others. It impacts on learning, job seeking and employment. And of course, we know it impacts on mental health and in the capacity to engage in mental health interventions, particularly where they're verbally based.
And talking therapies.
Yeah.
Absolutely. So if you'd like to learn more about speech, language and communication needs, and particularly language disorders, we recommend you go to the RADLD website, and there's some videos of young people with language disorders, and particularly one called Seb. And Seb is an adolescent who talks about his experience of having a language disorder, as does his family, and his teachers talk about the impact on Seb and his development. So thank you for listening to our webinar today, and we hope that you keep in mind that 50% of young people coming to our services do have speech, language and communication needs.
Thank you.